My topic is MRI versus CT in the ED, and it'll be entirely irrelevant if you don't have an MRI. So I am curious, who does not have access to an MRI? One, two, so quite a few. So it might be a good break time, I guess. I don't know. I remember when I was at Denver, then General, now Denver Health, and we didn't have one. We had to ship people across town. Then we built one into a trailer, and then they finally incorporated it into the building itself. But at that same time, across town, there was a university hospital, there was a private hospital, and there was the VA. And all three of them had MRs. This was probably late 80s. And it was said that we in that block had more MRs than Canada. And I don't know if that was true or not, but certainly a lot of us have had MRs for a long time, some still not. The main issues, of course, is availability. So as we're talking about, some people just don't have them. And even if you do, MR scanning is often kind of business hours, and you can't get it in the evening, you can't get it at night, you can't get it on weekends. We can, but you have to often call somebody in. Scanning time is a lot more on an MR. So, especially if you have a slower magnet, so magnets are graded in terms of Teslas. So 0.5 Tesla is what most of us started with. I think we might be up to a 1.5. Some academic centers are up to a 3. And the stronger your magnet, the quicker the scanning time. But for a lot of these, like a brain MR, it might take you 45 minutes if you're doing some kind of contrast with brain. That might be an hour on the table getting the scan. So if you compare that to a helical CT, it's literally seconds. It takes more time to get the patient off the gurney onto the gantry, then back onto the gurney, than it does to do the scan. So your MRs are going to have to get a whole lot quicker if they're going to really compete in the ED with CT scanning, if throughput time is still a significant issue. You might be interested to know the strongest MRI currently made is a 9.4 Tesla, 45-ton magnet, which actually has a stronger magnet than the Hadron Collider. So I don't think you'll be getting that in your ED anytime soon, but it does suggest that, anyway, the MR technology continues to expand. I think most of us understand that MRs see some things better, but actually CTs see some things better. So CT, the traditional teaching has been that we see things like bone better on a CT scan. So in the days, if you're really worried about a skull fracture, a CT scan would show that probably better than an MR. MRs, of course, show soft tissue generally better. So if you're worried about an epidural abscess or even the nerve roots coming out of the spine, you're not going to see any of that with a CT scan. So we all understand that there are some things that CT is just fine for, and other things that really are going to require an MR. Anytime we're dealing with the issue of CT scanning, of course, the issue of radiation exposure comes up. So if you look at, I think it's on your syllabus, if you have a table there, and it talks about the probability that a child will have no malformation. So this tells us that baseline birth defect rate is a 3% rate, and you don't start getting into any kind of increased birth defect rate until you get a significant radiation exposure. So one of the other confusing things is that we have all these different units of measurement for radiation exposure. So 1 rad is 10 millisieverts. A rad is essentially the energy emitted, the X-ray energy emitted, and the millisieverts or the sieverts are the energy absorbed. So 1 rad is 10 millisieverts, and therefore if you take this absorbed dose to the conceptus and divide by 100, you get your millisievert radiation dose. So you see, you don't start getting a increase even in the cancer risk. First of all, the birth defect question is essentially a non-question. You need something on the order of 50 millisieverts to start even getting into that range at the organogenesis stage of development. So even if you're doing like whole body radiation, you know, the Pan-Man scan, you're not going to be exceeding that dose to the fetus. So the question is more the probability of future malignancy in the fetus and the child as he or she develops. And even that, you're not getting into any increased risk until, as you can see, you're ticking up from the 99.7% chance the child will not develop cancer, 99.6 at 1,000 millirads, or 10 millisieverts. So the 10 millisieverts is about a belly CT scan, and so that'll increase the risk by 0.1%. So if you start talking about the absolute change, like in 0.1%, it's small, but if you start talking about the relative risk, just like in everything, it's not hard to double the risk with radiation exposure, but you're still generally talking about a very small risk overall. Now, there's one thing Rick had in here that I wanted to correct, so we're all not paranoid about flying. He wrote, an abdominal CT is equivalent to the radiation associated with a 7-hour plane flight. I'm like, really? I fly not infrequently. Am I getting a belly CT scan worth of radiation every time I hit 7 hours? And that's over a factor of 1,000 off. So fear not, fellow travelers. If you're a flight crew and you're putting in about 700 hours a year, then that's somewhere between about 2 and 5 millisieverts, or a doubling of your baseline radiation exposure by just living on the planet. So that's 700 hours. The worst flight that I could find was Tokyo to Paris, which is a 12-hour flight, and for some reason, I guess, exposes you to more radiation, and that was still less than 1,000th of a CT scan of your belly. So unless you're flight crew, you probably don't have to worry about it at all, and even then, it's fairly low risk. I like table 1 in here, and this is something I often translate for patients. So if you're trying to convince somebody not to get that belly CT, you can say, you know, a CAT scan of your abdomen is 400 x-rays worth of radiation. And then if you really want to emphasize, you can say, like, so if you're there and it's like every click was an x-ray, click, click, click. So if you clicked 400 times, that's your exposure for a belly CT. And I think, and it's true, and I think it can be rather convincing. Paper 1 is a guideline published by the University of California, San Francisco, and they apparently just decided to create their own guidelines. They said, we've looked at the evidence, and this is some of the things that we have concluded. MRI during pregnancy, no one's ever shown any fetal harm, but we don't really know for sure. So the assumption is that it's okay, but it's still this big, powerful magnet, and I don't know, maybe the kid's gonna end up with a poor sense of direction. I don't really know if it changes something. So they do recommend, you know, obviously you don't wanna willy-nilly do even MRIs in the setting of pregnancy. If you do them, try to avoid gadolinium enhancement. It's not been shown to be teratogenic except in animals at high and repeated exposures, but you know, maybe not the best thing, not well studied. Iodine, if you're doing your CAT scan, iodine doesn't add any risk, so if you feel a need to do a CAT scan, you can feel free to go ahead and use the IV dye. Breastfeeding can continue without interruption even after IV dye. And then there's some controversy, but their suggestion is that if you're worried about PE, there's always this question, do I get the VQ or do I get the CT angiogram? One of the main concern about the VQ is, although I think the total body radiation is lower because it ends up getting concentrated in the bladder, then the dose to the fetus is actually higher than with a CT pulmonary angiogram. So they recommend, as do many, that if you really feel compelled to rule out a PE in a pregnant patient, that CTPA is the way to go. With respect to the question of belly pain, I think that's one of those nightmare scenarios. You pull up the chart and it says, 32-year-old woman, pregnant, right lower quadrant abdominal pain. You're like, oh, Jesus. So not only do you know that's going to take forever, but it's also going to be a battle between OBGYN and surgery. It's like, no, it's not us, it's them, talk to them, we'll see them after they see them. So this can be a prolonged process. This is a single study out of Italy, and you know it's out of Italy because they started with ultrasonography in 145 women, and it was indeterminate in only 40. So they had over a 70% we figured it out rate with just ultrasound in a pregnant woman. And it's like, God bless them, that would not be my hospital. If I get any kind of, I have had this year one patient, pregnant, belly pain, started with an ultrasound and they read it as appendicitis, and the surgeons even believed it. It was unbelievable. But I mean, it's almost reportable in my group that if you're actually doing an ultrasound and getting a positive finding, apparently it's much more common in Europe, where they've been doing this for many more years than we and are much better at it. But in their patients, where the CT scan was indeterminate, so it was 40 women, they then went on to get an MRI, and they reported everybody did great. We figured out surgical diagnoses in everyone who had a surgical problem, and included appendicitis and placental abruption. And I think there are some tubovarian abscesses, and there was some biliary disease, and they figured out everything, and they said everybody who didn't have something on our MRI, it was 19 patients, we followed them along and nothing bad happened, they did great. So the MR figured everything out that needed to be figured out. Abstract number 3, 5 retrospective series of MRI looking for appendicitis. And they essentially report that it looks almost as good as CT scan. So the sensitivity was somewhere pushing 90%. The specificity was 95-ish%. And they said it seems to work really pretty well. Abstract number 4 was this mathematical calculation where they said, look, there are 3 ways, if the ultrasound strikes out, there are 3 ways that you can try to decide. You can get a CT scan, you could get an MR, or you could just take the patient to the OR and have the surgeon look. And in my view, that's sometimes been the best option. It's like, why can't you just take, OB and surgery takes the patient to the OR, and then you really know. But it does turn out, as I think many of us knew, that if you took the patient to the OR, the risk of general anesthesia and the procedure itself does pose a significant risk to the fetus. Prematurity doubles from about 12.5% to 25%. So their calculation said, you don't really want to take the person to the OR unless you know that she needs to go to the OR. And based on our calculations with future cancer risk and so on and so forth, MR appears to be the way to go. So I think if you have MR, pretty available, you're worried about appendicitis or some other intra-abdominal surgical problem, the takeaway is get the MR. If you have to transfer the patient to get the MR, then I think you've got a different calculation. And really, if you look at what data we have, the CT risk to the fetus is really minimal or non-existent for a belly CT one time. So the literature would tell you it's safe to go ahead and do the CT scan. There's sort of this gut queasiness I think a lot of us have that I don't know if I'd like my fetus radiated at 10, 12, 14 weeks gestation because we don't entirely know. But nonetheless, the care of the mother has to take precedence, and if what you got is a CT scan and the surgeon says, I need to know, then you go with the CT scan, and you shouldn't feel overly concerned about it. What we know about the exposure is that it's probably safe. But as we also heard earlier in the conference, the tech who's running the scan can have a significant impact on the radiation exposure. So people can try to dial this down, and then you can also even do more of a focused CT scan, so you don't have to scan from the base of the lungs all the way down to the pelvis like a typical abdomen pelvis scan. If it's this situation, you're worried, it's pretty focal right lower quadrant pain, you can talk to your radiologist, you can talk to the tech. Can we just do more of a limited scan, have a look right there, and hope for the best? Moving along quicker than I've been moving, apparently. The role of MRI in hip fracture, I think, is very interesting. So at the beginning of this, I talked about, as we've all been told, CT scan is good for bone. In fact, we've been told it's better for bone than MR. So why is MR better for hip fracture than CT scan? And I didn't know this for a while either, but it's largely because of two things. One, the hip is cancellous bone, so it's sort of that spongy kind of stuff, except on the cortex. And a lot of these old people, they're so decorticated, they just don't have calcium in their bones anymore, that the CT scan simply doesn't see the bone well. And the MR is much better at picking up essentially the soft tissue that their hips have become. So that's why MR works better. This talks about, as I think a few of these articles do, occult hip fracture. And this is a common occurrence. It's estimated that maybe up to 5% of hip fractures are not seen on plain film. And if you miss it, there are significant consequences. You can take a non-displaced fracture and turn it into a displaced fracture by sending the woman home. It's usually a woman. And then she walks on it and really breaks it. So the risks, of course, or at least the red flags would be some kind of general trauma, fell, some pelvic type of pain. And if they can't walk, then very high suspicion that there's an occult fracture. And if you haven't seen, it's generally either a pelvic fracture, so an inferior ramus, superior ramus, something like that. But if you've got nothing on the x-ray, then you've got to look farther. So a couple of these papers look at how good is CT at finding these fractures, and it's better than x-ray, as you might imagine, but it's not as good as MR. So I think if all you got is CT, or CT is much easier to get, then you can start with a CT and see if that hits. But if at the end of the day your CT is negative, your plain film's negative, she still can't walk, you got to go to MR. Let's see what our next topic is. Oh, wrist fractures. So now we're on to scaphoid fractures. So I'm curious because I've never done this. Is there anybody who is seeing, the typical Fouche kind of patient, wrist pain, negative x-rays, snuff box tenderness, worried about a scaphoid fracture, and you're actually getting an MR? I got one hand. So the traditional teaching has been, we splint them, we refer them, they stay immobilized, and then they get re-examined 7 to 10 days, and if they're still tender, then they get re-x-rayed, and so on and so forth. So there is some criticism of this, because for one, we don't know exactly how to immobilize people. So do you do a short arm or a long arm? If you just do a short arm, you still get some movement, and maybe if it's truly broken, that's putting you at a higher risk for avascular necrosis. If you do a long arm, and it turns out they really didn't need it, that's a pain to be walking around with long arm immobilization for 7 to 10 days. And then it's a significant injury that will usually go to surgical repair, and so often we're just delaying the definitive treatment. So the question is whether we should just be referring these people in the ED to direct MR. There are a couple studies looking at this. In one of them, when the x-ray was negative, fractures were identified in 22%, not all scaphoid. There were other carpal bones that were sometimes fractured. One of these other was a cost analysis, and is it just too expensive to go on and try to find the 1 in 6 of these patients who might have an occult scaphoid fracture by getting the MR? And again, all these cost-benefit analyses are the same. Your answer depends on your input data, but their suggestion was with time lost from work and so forth, that it's actually a more cost-effective approach by doing the MR right off the bat. I think for a lot of us, it's, again, the availability and then the time sink. So for me, we have these little whiteboards in the department that we're supposed to use, and it says, you know, if you're getting an X-ray, it'll take an hour, and if you're getting labs, it'll take an hour, and if you're getting an MR, it'll take 4 hours. And that's just sort of pre-printed in the room. So to start building any kind of pathway for me that includes an MR is just, practically speaking, not doable in a busy ED. But I think if potentially you could refer out, order the MR in some kind of a system, if you talk with your orthopedist and they say, yeah, why don't you just get the MR, I'll see him in my office. Maybe you can work something like that out. I don't see how you can work it out in the ED itself. Next article talks about the same question in knee injury and whether we should just go to MR when the X-rays are negative. And again, it's the same cost-benefit type of analysis. Are these people inevitably going to get an MR? And are we going to save some time and time off from work and so forth for the acute knee injury, generally the big swollen knee that comes in? And of course, you can look at it and come up with any conclusion you want. I think one thing to bear in mind, though, is that MRs are not that great in figuring out what is actually broken in your knee. So if you look at a couple of these articles, they talk about what is the sensitivity of MR and actually accurately identifying your ACL injury, the MR in identifying your meniscus injury. It looks like it's pretty good for a medial meniscus injury, not so good for a lateral, pretty good for ACL, but in terms of predicting the need for surgery, not so good there either. And then even when you step back farther about who actually needs surgery, I think if you talk to 2 orthopedists, you're going to get 2 different orthopedic opinions. I'm reminded of 2 different articles published in the New England Journal looking at sham surgery operations. So they took patients with known ACLS injury in one of these studies, and they all got an operation, but half of them, all they did was open the knee and kind of squirt some stuff in there and then close the knee up. And then the others, they did an actual ACL repair, and the outcomes were identical in the PT group, no surgery, and the actual surgery group, and there was an almost identical study looking at medial meniscus tears and surgery versus sham versus real. So a lot of the orthopedic procedures, we're not even sure how valuable they are. So the need to identify as best we can with an MR what the actual injury is seems a bit questionable to me. I'm happy to defer these down the line to orthopedics. I think we might be about done. Oh, there was one other point that's not in here that I thought worth making. And that's when the patient who comes in with a stroke-like syndrome. There are no papers in the database about this, but almost all of them in my institution are getting an MR eventually. So generally, we're doing the CT and the ED, and then they get admitted if they have a true stroke, and then tomorrow they're getting their MR. So I know that there is a move toward just starting with the MR. And one of the questions has come up, well, the CT is supposed to be good at bleeds, and the MR is better at stroke, so getting the CT first makes sense. There's one paper that I saw recently where the MR actually outperformed the CT with respect to bleeds. So we probably are approaching an era, or maybe are in an era, where the CT of the brain shows you nothing that the MR does not. So if you're seeing a patient, be it TIA-like thing that really sounded rather serious, or a stroke, and you're sure that somebody's getting the MR, and it's convenient to do so. Maybe they're being admitted, so if it takes 4 hours to get the MR, it doesn't matter so much. I think you can start beginning to make an argument that beginning with the MR, just skipping the CT makes some sense. So in summary, Rick says, key points, recommendations. Although fetal exposure to CT-related radiation is associated with no significant teratogenic risks and very minuscule carcinogenic risks, patients and physicians generally want to avoid CT radiation of the abdomen in a pregnant patient. Oh, one thing I didn't discuss specifically, one of those tables looks at fetal radiation dose, which I thought was very interesting. So if you radiate the head of a patient, we know how much their head is getting, but then the table has possible or probable exposures by the fetus itself. So as you imagine, you're radiating the head, you're getting less fetal exposure, but then as you move down, when you're doing a belly CT, the fetus is absorbing twice the radiation dose that the mother's getting. So it's an interesting change in the calculation. MR, good for belly and about the same as a CT, probably, maybe depending on your radiologist's experience. MR for that hip fracture you're worried about occultly. Scaphoid fracture, we know MR is good, and what role it plays acutely, I think, remains in doubt. And then the same with the knee.